Coming up next on Primary Care, cancer and community engagement. Community engaged research is reshaping the fight against cancer.
Whether it's genetics, whether it's screening, whether it's treatment, and helping people understand those dynamics or those issues, we need to bring community members to help us, again, shape the education.
Hello and welcome to Primary Care, the show dedicated to improving the health of African Americans. I'm your host, Dr. Lonnie Joe. African Americans have the lowest survival rates for most cancers and the highest overall cancer death rate of any racial or ethnic group. According to the American Cancer Society, these disparities are often linked to socioeconomic barriers, late-stage diagnoses, and limited access to quality care. But there is hope. Across the country, organizations are working tirelessly to close this gap by advancing research, expanding access to screening, and empowering communities with the knowledge and resources needed to take charge of their health. One such organization is the Karmanos Cancer Institute Office of Community Outreach and Engagement, led by today's guest, Dr. Hayley Thompson. Dr. Thompson is a professor at the Wayne State University School of Medicine. She also directs the Center for Health Equity and Community Knowledge in Urban Populations, known as Checkup. Dr. Thompson, welcome to the show. Thank you for joining us.
Thank you so much for having me.
Hayley, help us understand the role of the community engagement in this whole cancer battle that we fight on a daily basis. Why is it such a critical part of the fight against cancer to have the community involved?
Mm-hmm. Well, I always like to do a little bit of education here. I represent Karmanos Cancer Institute, and we're what's called an NCI, or National Cancer Institute designated comprehensive cancer center. There are only about 57 in the country. Mm-hmm. Michigan is lucky to have 2. We have Rogel Cancer Center, University of Michigan. Karmanos Cancer Institute is affiliated with Wayne State University. And as part of that work, we received something from the National Cancer Institute called a Cancer Center Support Grant. So it's really top down from the NCI that we have this mandate to have a community outreach and engagement component. It is recognized that cancer centers occupy a really unique position in their communities, mm-hmm. as we are charged with not only treating cancer, right, but also just overall reducing cancer burden in our catchment areas or the communities we serve. When we think about that, we think about a whole cancer care continuum. It starts from prevention, risk management, screening, diagnosis, treatment, survivorship care, right, what happens after you're diagnosed with cancer mm-hmm. and treated, and even end-of-life care. And so there's no way we can cover that continuum of care if we stay within the 4 walls of our hospitals mm-hmm. or stay within the 4 walls of our universities. We have to connect with communities. We have to have strategic partnerships with primary care settings, with community-based organizations, social service agencies, public health agencies, in order to make a difference across that whole spectrum of outcomes.
So your work bridges research and also real-world impact.
Absolutely.
And how it affects patients.
Yeah, we often say in our office that our job is to connect our communities to our science and our science to our communities, mm-hmm. right?
So it's a two-way street.
It's absolutely, it's a two-way street. They call it bi-directional communication. But we collect a lot of data, and we obtain a lot of data from the state and from our hospitals mm-hmm. to understand what's happening in terms of cancer trends, cancer incidence and mortality in the communities we serve. We also talk to people who are on the front lines, either they're cancer survivors, or they're cancer caregivers, or they're advocates, and they also let us know what their priorities are in terms of cancer, what they're seeing in their neighborhoods and communities when it comes to mm-hmm. cancer. And that's supposed to inform our research, that's supposed to inform our programming, right? And it's also really important that we communicate our science well to the community as well.
You know, Hayley, we're collecting a lot of data, especially with the technology now. I mean, mm-hmm. we are in an environment and a time frame right now where we have information overload. It's almost mm-hmm. impossible to stay current like you want to with all of the bombardment of sources of information. And with that said, how does disparities fit into this? I mean, cancer disparities are a well-known documented issue. Are we making a difference in terms of being able not just to collect the data, mm-hmm. but to interpret the data and implement programs that can give us the better outcomes?
I think we're doing a better job of that locally and nationwide. And I think it has a lot to do with community engagement, because we are not only just viewing communities and people living in communities as sort of just passive recipients of programs. We're involving them in creating programs, right? And letting communities tell us the best way to implement programs. So I think those kinds of strategies make a huge difference when it comes to cancer disparities, especially when we're talking about people of color, African Americans, Latinos. We have to work with people in communities to understand the best ways to communicate what we know, the knowledge we have, and the best way to bring people into care as well.
How do you implement that in terms of a population or community, in terms of early detection and prevention?
Yeah, so maybe one of the ways I can share an example of one of the ways that we do that. We have a program right now that we call Real Talk. It's our Real Talk series, and it's focused on cancer screening and addressing disparities that we see in terms of people being adherent or compliant with cancer screening guidelines. We want to make sure that people are screened for breast cancer, screened for prostate cancer, screened for colon cancer and lung cancer on a regular basis according to guidelines, so that cancer can be identified at an early stage when it's easier to treat. So in our office, we've created materials and programs through this Real Talk series to make it easy to train community members. We call them lay health advisors. We give them the tools to teach people in their communities and their social networks about cancer screening. And even through those programs, it's not just about education. I'm a behavioral scientist, right? I'm a clinical psychologist. And we know that knowledge alone is not enough to change behavior.
Exactly.
Right?
Exactly.
We have to actually, sometimes we have to address people's attitudes, right? Or their fears or their mistrust. But oftentimes, we have to acknowledge that people live in communities, they live in families, they live in neighborhoods that are subject to policies, right?
Sure.
So we need to make sure that we are really giving people support, whether it be with transportation or with the financial piece of it.
Exactly.
Really giving people the support to get the care that they need and get the screening that they
So
need.
I find that when we look at population health, okay, and deal with those demographics, I find that when we are able to deal with the socioeconomic differences, we reduce disparities. So your program, like having the ability to actually have conversations with populations as a whole, probably have to have an approach that says, let's see if we can reduce disparities in a particular area, whether it's Southwest Detroit or West Side or East Side of Detroit. Is that the approach?
Yeah, absolutely. We, like I said, we draw upon a lot of data to understand where maybe the needs are greatest. But you said something that I think is really important in terms of looking at this holistically. For many years in healthcare, we had this concept of cultural competence, right? So when you work with people of different groups, different backgrounds, particularly cultural backgrounds or different racial and ethnic groups, it was important to understand culture and kind of norms within certain groups to provide high quality care. Now we talk about structural competence, right? So how do we understand the neighborhoods or the conditions in which people live, and maybe what they need or what they don't have enough of that prevents them or serve as barriers to care.
From a geographic standpoint of view, we know you guys cover almost every county in Michigan in terms of the service you provide and the data that you collect. How has, and what trends have you seen from a Michigan standpoint of view? Are we looking at east side of the state versus the west side of the state when it comes to a particular diagnoses or a particular area of delivering care? How's that working in terms of the state of Michigan as a whole?
Well, actually, Karmanos, the catchment area for Karmanos Cancer Institute is half the state of Michigan, so it's the eastern half of the state, 46 of the 83 counties in Michigan. But even within that, I think it tells you a lot about probably what's happening on a statewide level. We divide it up into 5 regions.
But you've got most of the population, though.
Yeah, 6.8 million people.
That's right.
And again, we're thinking about the whole continuum of cancer care, not just people who are diagnosed with cancer or their families. We're thinking about it, again, holistically. And we have data that covers Detroit and Southeast Michigan, but also data that when we see different trends when we go to Central Michigan and even Northern Michigan. But certainly across our whole catchment area, first of all, cancer deaths in our catchment area tend to be higher, or mortality rates are higher in our catchment area, that eastern half of the state, compared to the United States as a whole. So we pay close attention to that. But in terms of cancer deaths, we see certainly prostate cancer, mortality rates higher in our catchment area compared to the rest of the country. Lung cancer death rates are higher in our catchment area as well.
So in your data collection process, have you seen the ability where having that information has had an effect on the focus of research? Has there been a direct outcome that says, because the data shows this, this is what we need to research?
Absolutely. Oh, absolutely. So, I mean, certainly I think about behavioral research. One of the things we're doing, because we know what the lung cancer incidence and mortality rates in our catchment area, we know that they're high and higher than the rest of the country. From a behavioral perspective, we're doing much more to encourage people to get screened for lung cancer, right? So that's a newer screening. Many people don't know much about it.
Low dose CT.
Yes, exactly right. That's exactly right. Starting at age 50 and based on your smoking history. You know, we've done listening sessions, community listening sessions across the state. We've done it in Detroit, we've done it in Flint, we've done it in Central Michigan, because we want to, and doing these listening sessions with smokers and former smokers to understand and get their perspectives, again, engaging them in a process of creating new messaging and new ways to reach people in the community.
So you're telling this story in all the various areas. However, the socioeconomic aspect still comes back to the forefront of this. How are people handling this and dealing with the inability sometimes to actually be present, afford services, find themselves in the mix in terms of being able to take advantage of all of the work that you do, and also the outcomes? I mean, are we really doing a better job in certain areas according to the numbers? Can we say, for instance, that prostate cancer in Hispanic men above the age of 55, I mean, do we have any data that would be that specific to talk about where we were and where we are now and the trend that's occurring?
I mean, overall, cancer in the state and cancer in the country has been declining. Although certainly for certain groups, particularly like for African American populations, it's been declining at a slower rate, right? So this is part of the work that we're doing to kind of get more granular data so we can understand more what's happening with in specific communities and with specific groups.
So basically, there is progress.
There is progress.
I mean, we can look back now and, you know, connect the dots and say, hey, we've got the trajectory, you know, right on target and where we're headed.
Well, yeah, we have a long ways to go, though.
Right.
And I appreciate what your point about socioeconomic status and those challenges. You know, more and more, and we're doing this in our own work. We don't only want to identify people who are off schedule for a mammogram, or maybe they've never had a colonoscopy. We also need to understand their social needs, right? So bringing in and doing much more incorporation of social determinants of health, right? And assessing those social determinants of health at the same time when we're trying to find out if they need health care. Because again, if somebody is worried about where the next meal is coming from, or they don't know how to pay their light bill, they're not going to prioritize screening.
Right, exactly, because if we were to flip this a little bit and say this is about food or food service, we would take a totally different approach, and the economic problem of being able to afford it, where it's located, whether there is a supermarket in your neighborhood or not, would come to the forefront of all the data that we collect to say, this is where we need to focus to make a difference. I mean, if all of the pneumonia is in Highland Park and all of the antibiotics are in Dearborn, do we take the patients with the pneumonia to Dearborn, or do we bring the antibiotics to the patient? Those kind of socioeconomic points along the way have to be addressed, and it's so good to hear that you guys are in the forefront of collecting this data. Dr. Thompson, I feel like I've done 1,000 health fairs in terms of community involvement and engagement and education. You guys do it on a level that has brought a different aspect to this also, and a good measure of success in achieving this. But how do you feel about the barriers that you face in terms of community education?
So one of the ways that we try to address barriers in reaching people is through strategic partnerships. You know, I have a great team in community outreach and engagement, but we're only so big, there's no way we can do it alone. I really believe in the power of collaboration. We have what we call a research and advocacy consortium, and we actually work with community organizations to help do this work as well. It's something that we're really excited about right now. We're working with different organizations, such as I'll mention a couple of strong partners like Detroit Community Care Network under David Underwood and Third New Hope Baptist Church, Detroit Parent Network with Jametta Lilly. Those are two examples of organizations we're working with who already, we're working with their teams and their staff members who have a lot of reach in the community already, right? And we're bringing them in to support the work, and we want to support their work as well. So many of these organizations have community health workers who are already doing things in neighborhoods to reach people, to support people in terms of social needs and healthcare. So we're trying to work together. We have to collaborate. We have to see where do things fit? You know, where's the synergy? Yep. We're doing this also in central Michigan and the northern regions too, even going up to the UP. So that's the approach that we're trying to take.
You're putting a lot of miles on a car, huh?
It can get that way. It can get that way. But you know, luckily we have Zoom and phones and things like that to help with the communication.
Good. So basically, there is progress being made in terms of getting the word out, spreading the word properly, talking about how questions get answered, talking about how resources get provided, and giving patients direction in terms of what the next step is for care.
Yeah, absolutely. Again, it relies on trained people who are prepared to take all of that on. Not only people who have, like I said, not only that cultural competency, but that structural competency and are knowledgeable about cancer, but also very knowledgeable about how to help people overcome the barriers to care. Community health workers are key. Patient navigators are also key. Navigation and navigators, that's very common in the cancer care world. People who really try to help people navigate or cross these hurdles or barriers to care.
Tell us about cancer action councils and how survivors of cancer, diagnosis and treatment, along with caregivers, get involved.
So in about 2016, we started our first Cancer Action Council, and this is actually a model. I'm originally from New York, and so this was a model that I worked with in New York City and learned from one of my mentors there. But Cancer Action Councils are groups of cancer survivors, caregivers, and advocates who want to make a difference when it comes to moving the needle in terms of cancer burden. So we call it community organizing around cancer, or community organizing around cancer research. We train these individuals who may or may not have a strong scientific background, but again, they know their lived experiences.
So there's a direct connection between these councils and the research component?
The research component, yes. Absolutely.
More than just sharing data? Or?
More, yes, absolutely. Oh, so with each of these groups, and we have about 8 of them now, but they represent different neighborhoods and different populations. We have a Black Men's Cancer Action Council. We have one that represents Arab American women. We have a rural Michigan Cancer Action Council. We provide some basic training about what is cancer, what do we mean when we talk about cancer research, and we go through exercises so they identify their priorities that they know are salient for that group. Right, so our Black Men's Cancer Action Council, for instance, certainly prioritized the financial burden of cancer care, and they've created programming around that, medical mistrust among Black men in cancer care, and they have been very involved in our Real Talk prostate cancer education series, and training men in the community to teach other men about prostate cancer.
You touched a little bit about church relationship. You mentioned Third New Hope, which we know well. Tell us more about your activity, because I know you've been in the churches. Tell us more about your activity in the churches. Detroit is a church community for any ethnicity, okay? And basically that has always been a way to actually steer progress through the church connections and involvement. Tell us about all the successes you've had with the church community here in Detroit.
Oh, sure. So, but right before the pandemic, I was fortunate to have Dr. Roy Wilson, who used to be the president for Wayne State University. He introduced me to Bertram Marks, who is an attorney and pastor in the area that many people know. And he was part of an organization, or is part of an organization called the Faith-Based Genetics Research Institute. Even hearing those words together, it's like faith-based and genetic research.
Do they
like,
fit?
Yeah.
Right.
But it's important because they believed in bringing particularly Black groups, Black populations into clinical trials, into research, and that includes genetic research. And that is, as you know, the future of medicine, kind of precision medicine, you know, moving away from an approach that is one size fits all and looking at your specific genome, your specific, your genetic makeup to treat your cancer. So when we met, we started working together and formed a faith community research network. And right now, that's about 14 churches, predominantly Black churches in Metro Detroit, coming together around cancer and other health equity areas, and working together to educate their congregations, and also, again, always to connect people to care. So we have done programs around educating people around precision medicine and genetics and genomics and what it means for health. Right, and we've educated people around clinical trials, and that was amazing because we saw these really strong increases in when we did pre-test and post-test, before and after our programs,
Exactly.
people saying like, oh, people like me, people of color, should be more involved in clinical trials. We saw huge increases in that, up to like from about 60% of the people agreeing with that statement to 90% of people agreeing with that statement, and feeling like they wanted to be a part of clinical trials. So increasing awareness and increasing people's sense of relevance to their own lives, that research matters.
Our community is making progress. We're still behind the 8 ball in terms of clinical trials. We across the board, our numbers have improved, but still a long way to go. The other area that you just mentioned is going to be genetic testing going forward in the future, which is going to be another educational piece that has to be discussed with a community like this. However, making the progress in clinical trials that we've done in the last decade or so is going to be a godsend in terms of how we help people get to the next level in terms of genetic testing, understanding what it is, how it fits into your own individual testing, family members testing, and what happens in the future, what you can expect. I went through genetic testing with family members myself, and it sheds a light on non-scientific people in terms of where we actually can arrive at if we participate. We still got to get over these hurdles and these barriers in terms of participation and getting the understanding and the message out there to do it. But here again, I think you're right. That is certainly the wave of the future, even down to whether or not, if 3 medications seem to be good for you, and I give you one, I now can determine that that one is really not the best one for you because of your genetic makeup. You need to switch to this one, and they're in the same class. So that is something to look forward to in the future. Has this research gotten to the point yet, though, that we can start talking about a blanket approach to this for communities? I mean, do you see, especially with the experience that you have, do you see communities being faced with a genetic testing approach in terms of how we actually look at cancer in the future? Are we on the cusp of learning or being taught how we actually deal with the diagnosis, early detection, prevention, which is another issue, but here again, compared to what we do now in terms of treatment and chemo and all the radiation and all those things, are we on the cusp of a new way of looking at how we tell this story about early detection and cancer treatment?
Absolutely, I think so. And the way you described precision medicine was, and genetics and genomics and the role of all that was perfect. I think it needs to be integrated. We have a history of certain types of education, right? When it comes to screening, we talk about, annual tests and so on, but we need to tell, a larger story that prevention is not, screening and prevention are not the same, right? Screening can detect a cancer, but you can actually start to prevent cancers, right, if you understand your family history and your genetics. So I think that we are on the cusp of a new era where we need to talk more about these different approaches to cancer prevention and cancer control. And just to connect it back to what we were just talking about, we have one of our Cancer Action Councils focuses on genomic and genetic research, and they're mostly faith leaders who are part of that, again, connecting back to the Faith-Based Genetic Research Institute. Aside from my work in community outreach and engagement, I actually have a funded research study now where we're working with those community members and those faith leaders to develop new ways and adapting ways to educate Black cancer survivors about the importance of genetic counseling and genetic testing, right? Because if you have been diagnosed with cancer and you have a strong family history, it's ideal for you to be the person who is first tested, right? That can give so much information to your family members and their own cancer risk. So it's been really exciting to, again, involve them in the work. So it's not just that I'm creating something and sharing it with people. We're developing it, co-developing it. We're doing it together. And we need their language, we need their insights in terms of how do we frame things. They can let us know what we might expect in terms of people's questions, what they may or may not understand. So that's really exciting work. And I think that's the approach we have to take, whether it's genetics, whether it's screening, whether it's treatment, and helping people understand those dynamics or those issues. We need to bring community members to help us, again, shape the education and shape the approach.
All right. Having the conversation, having the discussion is paramount. It is so germane to actually helping people understand, including within families themselves. We just had a family situation on the primary care side. We found out that there were 4 females in the family right here in Detroit that all had breast cancer diagnosis, and nobody knew that the other one in the family had it. And a lot of that was rooted and based in, the myths surrounding cancer care and cancer treatment, which we've suffered as providers for a long time. When they cut you open, it's going to spread, all of those kind of things. Have you experienced any barriers in terms of the myths and the conceptions that and the premonitions that people have about cancer development and treatment?
Absolutely. So in our Real Talk series and those programs, we directly address myths. So things that I remember hearing when I grew up are still prevalent. Like if you have cancer and you have surgery, the air is going to cause the cancer to spread.
Exactly, it spreads.
Right, right. So
when
that's
the air hits it, it spreads. Yeah.
Right. Yeah. So we that's something we dispel. We challenge that.
Or one in the southern part of the country was, if they start you on insulin, you're going to wind up on dialysis. I mean, that was prevalent in the South for many years.
Right, right. Or when we think about genetic risk, that let's say genetic risk for breast cancer, that it's only passed down through your mother's side of the family. No, well, that's part of the education. When you're talking about genetics, you get information, genetic information from your mother's side, you get genetic information from your father's side. So it's both. So you need to understand not only your mom's family history, you need to understand your dad's family history as well. It's really important. And those are things that people they just don't know.
Yeah, and not knowing is very dangerous, especially in a modern society like this right now. I know, like I said earlier, we got information overload, but there is a way to actually get to the facts about any of these situations. Even if it's called a second or a third opinion, there's no excuse for not being able to drill down and get an understanding of what we're dealing with in cancer prevention and treatment. Dr. Thompson, thank you for joining us today. It's certainly been a pleasure.
Thank you
We
so
will
much.
do this again. Our guest has been Dr. Hayley Thompson, professor in the Department of Oncology at Wayne State University School of Medicine and Associate Center Director for Community Outreach and Engagement. Community engagement related to research is essential in addressing cancer disparities. It gives voice to individuals and communities and helps shape treatment that truly make a difference for our patients and our lives. For Primary Care, I'm Dr. Lonnie Joe.